All right, let's get right into it. If you're a pathology trainee, you know that feeling, right? That huge, complicated soft tissue specimen lands on your bench, and suddenly you're the one writing the report that's going to guide some major treatment decisions. Well, we're going to walk you through how to nail it every single time by using the definitive protocol. So you walk into the gross room, and there it is, this massive, intimidating tumor. The surgeon's waiting to hear about the margins, the oncologist absolutely needs the grade, and you're the one who has to pull all the answers together. Yeah, it's a pretty high-stakes situation. But here's the great thing. You don't have to wing it. You don't have to reinvent the wheel. There is a very clear, super structured, and mandatory roadmap to follow that makes sure every single crucial detail gets covered. And this is it, the CAP protocol for soft tissue tumor resections. This isn't just a friendly suggestion, it's a requirement for accreditation. And it's designed to create reports that are standardized and high quality, so a surgeon in one hospital can perfectly understand a report from another. It's all about clarity and ultimately patient safety. You know, everything really starts at the cutting board. The work you do during the gross examination literally sets the stage for the entire report. If you get this part right, everything else, from the microscopic exam to the final stage, is going to be built on a rock-solid foundation. Having a system here is completely non-negotiable. First, you've got to understand the surgery itself. What exactly did the surgeon do? Then, you get your rulers out for precise measurements in all 3 dimensions. Next, and this part is absolutely critical, you use ink to mark every single surgical margin. That's the step that allows for a definitive microscopic assessment later. And finally, you thoughtfully section the tumor, making sure you get good representative samples from all over, especially from the area closest to that ink. Now, what's really fascinating here is how the surgeon's choice of words directly impacts how we look at the specimen. Knowing if they performed a marginal versus a wide resection gives us so much crucial context. As the protocol notes explain, a marginal resection probably has microscopic tumor at the edge, while the wide resection is designed to have a nice, clean cuff of normal tissue. This isn't just wordplay, it's totally central to understanding what you're looking at. Okay, so we're moving from the cutting board to the microscope. Once our slides are ready, we're zeroing in on 2 fundamental tasks. First, giving the tumor a precise name based on what we see, and second, assigning it a grade to predict just how aggressively it might behave. And this is a point I really can't stress enough. The grade is not just some academic exercise. The protocol makes it clear that the clinical staging of these sarcomas is largely determined by the grade. It's a key piece of the puzzle the oncology team uses to decide on treatments like chemo or radiation. It's a huge deal. So, how do we figure out that all-important grade? Well, the CAP protocol points us to a very specific, standardized method, the FNCLC system. This is the gold standard because it's reproducible and does a fantastic job of predicting patient outcomes, all just by scoring 3 key features under the microscope. And this table shows just how beautifully simple the system is. We're going to score 3 things. First, differentiation. How much does the tumor look like its normal counterpart? Second, mitotic count. Basically, how fast are the cells dividing? And third, tumor necrosis. How much of the tumor is dead? Each one gets a score, and then we just add them up. Let's just run through a quick example to see how it works. Okay, so let's imagine we have a sarcoma where we're pretty certain of the histologic type. Maybe it's a classic myxofibrosarcoma. Well, according to the FNCLCG guidelines, that gets a differentiation score of 2. Simple enough. Then we start hunting for the area with the most mitoses. Let's say we count over 20 mitoses in 10 high-power fields. Whoa, that's a lot of activity, so that easily earns a mitotic score of 3. And finally, we estimate the necrosis. We see some, for sure, but it's definitely less than half the tumor, so that gives us a necrosis score of 1. All right, now we just do the math. 2 plus 3 plus 1 equals a total score of 6. And according to the FNCLCC system, a score of 6, 7, or 8 means it's a grade 3 or high-grade sarcoma. See, when you break it down, it's a really clear and logical process. So we've named the tumor, we've graded it, but now for the million-dollar question. Did the surgeon get it all out? This is where we shift our focus to the margins of the specimen and any lymph nodes that might have been removed. It really boils down to this one simple question. Is there tumor at the ink? If the answer is yes, the margin is positive. If it's no, it's negative. And a positive margin is the single biggest predictor of local recurrence, meaning the tumor growing back in that same spot. But here's the thing. Just saying negative isn't the whole story, is it? the clinical team needs to know more. I mean, if the tumor is just a tiny fraction of a millimeter from the ink, that's a completely different situation than if it's 3 centimeters away. The risk of it coming back is way higher when the margin is that close. And the CAT protocol is super clear about this. Note J specifically recommends reporting the exact distance for any margin that's less than 2 centimeters. So that means you got to get out your ocular micrometer and measure it. That precise number is a critical piece of data for that patient's care plan. Okay, we are in the home stretch. We've done the gross exam, we've made our diagnosis, we've graded the tumor, and we've assessed all of the margins. Now, it's time to put all of that information together into the final report that everyone is going to rely on. This is basically the grand finale of all our work. The PTNM staging system takes everything, the tumor size, the grade, where it was in the body, the nodal status, and synthesizes it all into one unified stage. And that stage is the universal language of oncology. It gives the best estimate of the patient's prognosis. Now, check this out, because this is a really important point. Staging is not one size fits all. The AJCC system makes it clear that the tumor's location is critical. I mean, look at the difference here. A 5-centimeter tumor in the leg is a PT1, but that same 5-centimeter tumor in the head and neck, that's a PT3. The anatomic context completely changes the stage, which is why accurately reporting the site is so important. So, if you only remember 3 things from all this, let it be these. First, grade is king. It drives both staging and treatment. Second, margins predict the future. They tell us the risk of the tumor coming back in the same spot. And third, all this info has to go into the synoptic report. That checklist format isn't optional. It's the mandatory way we make sure every critical finding is communicated clearly and consistently.
You know, at the end of the day, that pathology report is so much more than just a document. It is the definitive story of a patient's cancer at that one moment in time. It's the roadmap that the surgeon, the medical oncologist, and the radiation oncologist will all use to figure out the path forward. Your skill and your attention to detail in telling that story clearly and accurately, well, it makes all the difference.